discussing and showing you about the pancreas. I think my screen is visible to all.
Yes, sir, it is visible.
Yeah. So I'm going to start the discussion. See, for centuries, the pancreas has been a mysterious and a hidden organ, and that has received very little attention. It was, though, first identified by the Herophilus around 335 to 280 BC. He was a Greek anatomist and a surgeon. But after a few hundred years later, there was no progress, and Rufus of Ephesus, another Greek anatomist, gave its name as a pancreas. It was in 1642 that Johann Georg Wilson described the main pancreatic duct, and that starts the pancreatology in the world. Another French physiologist was the Claude Bernard, and he described the pancreatic exocrine function in 1849 and 1856 around, and he is considered the father of the pancreatic physiology. In 1921, the Frederick Banting and Charles Best, they have discovered the insulin, and for this discovery, the Frederick Banting was given a Nobel Prize for Medicine in Physiology in 1923. And beyond that, the era started for the pancreatic surgeries in 1940s when Alan Whipple performed the first Whipple surgery. Then later on advancements came for the pancreas. So the pancreas, the word pancreas originates from the Greek word pan meaning all and the pancreas meaning the flesh. Depends named on the nature of this organ, which means all flesh. So it's an elongated lobulated gland which lies in horizontally in the upper abdomen, and most of the pancreas is retroperitoneal. Only the tail, the terminal part, is considered the intraperitoneal part, and the organ extends from the duodenum till the splenic hilum. It's around 15 to 20 centimeter long, and the weight of the organ is around 75 to 100 gram. So now I'm discussing the part of the pancreas. Pancreas is divided into head, neck, body, and tail. An uncinate process, which is extension of the head, also considered another part of the pancreas. So the head, which lies into the C loop of the duodenum, and the uncinate process is a part of the head which goes behind the vessels, behind the SMB and the SMA. It hooks posteriorly. The neck is a very narrow part, around 2 centimeter in the width, which extends from the right of the SMB superior mesenteric vein and up to the superior mesenteric artery. Then laterally comes the body of the pancreas, which crosses the aorta around L1 vertebrae. And the last part, which goes up to the splenic hilum, is called tail of the pancreas. Though there is no clearly demarcation between the body and the tail of the pancreas, still controversies and definition goes on between exactly defining the parts of the pancreas. Coming to the surface anatomy, pancreas lies deep in the upper abdomen. It lies behind the posterior most organ and lies in the epigastric and the left hypochondric regions, and it lies approximately at the level of the transpyloric plane. It spans transversely across the L1 and L2 vertebrae, but the organ is oblique, not perfectly horizontal. The head is little bit lower at the level of L2 vertebrae, and the tail, which is little bit higher, is close to the spleen up to the T12 vertebrae level. The nerve supply of the pancreas is from the celiac plexus, which give it to a sympathetic supply from the T5 to T9, and the parasympathetic supply comes from the brain as a vagus nerve. So now I am going to discuss about the blood supply of the pancreas, which is important for anatomy as well as for surgeons also. So pancreas is supplied from both celiac artery as well as superior mesenteric artery. The superior pancreatoduodenal vessels are the branches of the gastroduodenal artery, and the inferior pancreatoduodenal vessels artery as branches of superior mesenteric arteries. It also gets branches from the splenic artery, which again the branch of the celiac artery. The veins or venous drainage usually follows the arterial patterns. The pancreas drains into the superior mesenteric vein and the splenic vein. So now this diagram shows us the supply of the pancreas. The celiac trunk gives the proper hepatic artery, and which again gives a common hepatic artery, and which gives a proper hepatic artery and a gastroduodenal artery. So this GDA supplies the head of the pancreas, giving anterior, superior, and anterior posterior pancreatoduodenal artery. The inferior border of the pancreas also receives supply from the superior mesenteric artery, which gives inferior pancreatoduodenal arteries. Those are two, one runs on anterior, one runs on the posterior surface. And the body and the tail of the pancreas supplied by the splenic artery. The splenic artery gives rise to the dorsal pancreatic artery, which gives a right branch and a left branch, which we label as a transverse pancreatic artery. Apart from this, there are multiple other branches from the splenic artery, which supplies directly to the body and the tail of the pancreas. So this anatomy is mostly we see in the diagrams of the books. Later on variation also I'm going to discuss. The venous drainage of the pancreas, ultimately it follows the arterial pattern in most of the patients, and the vein follows the artery, and the drainage ultimately goes to the superior mesenteric vein and the splenic vein. So there is anterior superior and posterior superior pancreatoduodenal vein, which goes into the portal vein, and there is inferior pancreatoduodenal vein also, which drains into the superior mesenteric vein. Again, the body and the tail of the pancreas directly drain into the splenic vein through the multiple small branches. So this is general anatomy which I told you, but anatomy in books looks ideal, but anatomy in humans is individual. The anatomy we see in textbook is clean. The anatomy we encounter in the operating room is that's called real anatomy. As Sir William Osler has said, in human anatomy, variation is the rule, not the exception. So the what blood supply I have told you is just a generalized idea about the anatomy. There are a lot of variation exist. So now we discuss arterial supply variations. As I told, the pancreas supplied by SMA and celiac artery. The dorsal pancreatic artery variation is very frequent. It can arise from the celiac trunk directly, can arise from the common hepatic artery, can arise from the SMA artery. And the other pancreatoduodenal artery supply the pancreatic head that may originates from the common hepatic artery, right hepatic artery, rather than the gastroduodenal artery. And the inferior pancreatoduodenal arteries can have variations. They can directly come from the duodenal artery. Sometimes they are absent also. And this transverse pancreatic artery, which runs along the inferior surface of the pancreas, it may be absent sometimes, and sometimes can arise directly from the superior mesenteric artery. So there are accessory artery as well. Sometimes the complete blood supply of the pancreas is replaced from the SMA. So ultimately, the anatomy varies very widely. Any arteries which is surrounding the pancreas can give rise to the branches, and a lot of variation exists, which we should be remembering while handling the pancreas. Now, just I want to stress on the venous anatomy. That's called Henle's trunk. It's also called as a gastrocolic trunk of Henle. It also has a common variations. Recently, multiple variation has been described in a meta-analysis in 2018. So they have described this is the type 1 where the right gastroepiploic vein and the anterior superior pancreatic vein is superior right colic vein. These three veins, one from colon, one from the stomach, and one from the pancreas, forms the tripod vein of the Henle. So this tripod usually seen around 38% of the patient, but there are variation exists for this venous anatomy. Though this anatomy particularly important when we do some pancreatic resections or we do right colectomy. Another variations are uh, there are only two veins, no veins from the colon draining into the this tripod vein of the Henle. There can be one more extra vein, both are a superior right colic vein and the right colic vein draining into this vein and forming a trunk, which with trunk we label it as a gastrocolic trunk and draining into the superior mesenteric vein. We label it as SMV. The last diagram shows the common anatomy where the length of the common trunk is around 14 mm and it runs on the inferior border of the pancreas, just superior to the uncinate process of the pancreas. So the variation exists both in the hepatic arteries, pancreatic arteries, and as well as the pancreatic venous drainage. So we should be aware of these variations. And now the ductal anatomy of the pancreas. Pancreas is drained by a duct. We call it is a duct of Wirsung's, and the secretion from the pancreas, which are drained by the duct joined by the common bile ducts. They both join and form a common channel, and they drain into the second part of the duodenum. And the duct little bit runs on the posterior surface of the pancreas. But as I told, this ductal system also has a variation that I'm going to discuss. This is called pancreas divisum. It is a most common congenital pancreatic anomaly. Around 5 to 14% of the general population are affected. In imaging, the pancreas divisum can be found around 3 to 9% of the population. This happens because of the failure of the fusion of the ductal and the ductal system of the dorsal pancreas and the ventral pancreas during the seventh week of the intrauterine life. So pancreas is formed by the two systems, the dorsal pancreas and the ventral pancreas. In between the fourth and the seventh week of the intrauterine life, the pancreas rotates, the ventral pancreas rotates and the fuses with the dorsal pancreas. And after fusion, only one duct remains that we label it as a duct of Wirsung and the main pancreatic duct. The another duct uh, becomes non-functional. But as I told, anatomical variation in the pancreatic divisum, the minor papilla sometimes may be drained by accessory pancreatic duct. We label it as a duct of Centroni, and this can be a primary drainage in the cases of the pancreatic divisum. The best investigation to find this anomaly is secretin enhanced MRCP magnetic resonance cholangiopancreatography. It's a non-invasive modality to diagnose this ductal anomaly of the pancreas. So there are classification of this pancreatic divisum. Incomplete pancreatic divisum similar to the classic PD, except for the small branch, there is a communication between the two systems, and the prevalence is around 15%. The most common system of this pancreatic divisum is complete pancreatic divisum, which is around 70% of the cases, where ventral ductal system drains through the major papilla and the duct of Sanctorani drains through the minor papilla, and though no communication exists between the two ductal systems, that's the commonest pancreatic divisum. So it has been classified the incomplete, complete, and absent ventral duct. In incomplete, a very similar anatomy to the classic PD, except for a small branches communication existing between the two ductal system. A reverse PD is again a rare variant in which the complete absence of the ventral duct. There is no duct of Wirsung, and the entire pancreas is drained to the dorsal ductal system in this variant of the pancreatic divisum. So this anomaly we commonly encounter about the pancreatic anatomy. So now coming to the pancreatic physiology. So pancreas has a functions both as a exocrine and endocrine gland. Basically, pancreas is a gland which has both exocrine secretions through the ducts and endocrine secretion which directly goes to the blood. So I am now going to discuss about the pancreatic functions. The exocrine pancreas, it is around 90 to 95% of the total pancreatic mass. The remaining around 5% of the pancreas functions as endocrine gland. The exocrine pancreas has enzymes, secretes enzyme which helps in the digestions. So the exocrine pancreas produce the enzymes. Basically, the acinar cells produces complex enzymes like proteases, which helps to digest the proteins and amino acids. Amylases, which breaks down the carbohydrates and starches into the simple sugars. Lipases, enzymes which hydrolyzes the fat and helps in the digestion of the fatty acids. It also secretes the nucleases which break down the nucleic acids, DNA and RNAs. So basically, exocrine pancreas which secrete its juices into the duodenum, which ultimately mix with the food and helps in the digestion and the breakdowns of these all nutrients. And there are ductal cells into the pancreas which secrete bicarbonate rich fluid, which is produced by the alkaline, it has alkaline pH, and it neutralizes the highly acidic stomach content when the food in the stomach, which is acidic in nature, and enter into the duodenum. And there are multiple mechanisms involved. The cholecystokinin from the duodenum stimulates this bicarbonate rich fluid into the through the ductal cells, and ultimately it neutralizes the acidic pH of the food, and it creates ultimately optimal environment for the digestion and to function and protects the intestinal lining from the damage. And now pancreas, around 5% of the pancreatic mass has a endocrine function, which is again very important for the glucose metabolism. So there are islet cells of the Langerhans, which releases important hormones directly into the bloodstream. I'm going to discuss which are these hormones. There are beta cells, which constitutes around 70 to 80% of this islet cells of the Langerhans, which produces insulin and amylin. And insulin lowers the blood glucose by facilitating its uptake into the muscle and fat cells. There are alpha cells, which produces glucagon and which raises blood glucose level. There are delta cells into the endocrine pancreas, which produces somatostatin, a regulatory hormone, which inhibits both the secretion of glucagon and insulin. Then there are gamma cells, which produces pancreatic polypeptides, which helps regulate both endocrine and exocrine secretion and may influence the appetite. There are small amount of the epsilon cell, which produces ghrelin hormone. This ghrelin, which inhibits the insulin secretion and it stimulates the hunger also. So these are the cells of the endocrine function of the pancreas. There are many functions which are still not known about the pancreas as an endocrine gland. So I thank you for the patient listening.
Thank you so much, sir. Sir, that was a really enticing session, and we got to learn so much about the anatomy and physiology of pancreas, and it was surely very informative for the audience as well. I see Professor Konzo has joined the session. Uh, Good evening, Professor Konzo. I hope you're there. Dr. Mungardini, I hope you're also there.
Yeah, I'm here. Thank you so much for the invitation, and we really enjoy the presentation of Professor Bati. And I am with another resident from my university.
Hi, nice to meet you.
And as I told you, I really enjoy this kind of a series and episode that we created with the Magister Chirurgiae. And in this episode, we will treat the acute and chronic pancreatitis. So this important introduction will be really important also for the following presentations. So thank you so much.
Yeah. Thank you, Dr. Mungardini, for such a nice speech. And for everyone, Dr. Mungardini is a resident and fellow for colorectal surgery, and he is also the prime moderator for this session. And following, moving on to next part, we welcome Dr. K. Santosh Anand sir, who is there, and I can see him. Good evening, sir. I hope I am audible.
Yeah, you are audible.
Yeah, thank
Tell
you
me.
so much, sir. Sir will be presenting his part on pancreatitis, and we are really excited to uh, listen to him. So thank you so much, sir, for joining us. And I'll hand over the session to you. And sir is also a senior consultant and robotic gastrointestinal liver and pancreatic surgeon, and he's also published over 20 plus international articles. And we are really excited to have you on board, sir. Thank you so much.
Well, thanks for the nice introduction. Let me just set myself. Okay. I hope the screen is visible now. I will go for.
Yes, sir. The screen is visible. Yes, sir. We can start now.
Uh, Thank you, respected moderators. Thank you, Dr. Gajendra Bhatti, sir, for giving me this opportunity. So, topic given for me is acute pancreatitis. Where do we stand now? Now, pancreatitis is basically an inflammation of acinar cell to which there is a systemic response. Now, when the systemic response mounts high during the initial period, it's acute pancreatitis. When the systemic response is almost nil, but repeated acinar cell injury leads to exocrine initially and later endocrine injury leads to chronic pancreatitis. Now, acute pancreatitis may vary in severity. 80% of the time, they are self-limiting. Patient presents with pain, nausea, vomiting, requiring analgesics, maybe a couple of days or maximum a week of hospital admission, will not go to ICU. Once the pain and vomiting settles, patient can get discharged. So that is mild acute pancreatitis, which constitutes around 80% of acute pancreatitis people. Remaining 20% of the acute pancreatitis population develop severe systemic inflammation as a result of pancreatic necrosis, which may lead to single or multiple transient or persistent organ failure. Unfortunately, 20% of this group, 20% of acute severe pancreatitis may end up with mortality. Now, with the lifestyle changes, the global incidence has increased with an annual rise of 3%. We all know the most common risk factor for acute pancreatitis is alcohol use, followed by gallstones. The other causes include hypertriglyceridemias, hypercalcemias, autoimmune disorders, very common these days endoscopic procedures, trauma, medications, genetic mutations, and metabolic abnormalities. So these are the risk factors with or following which a patient may develop an acute pancreatitis. So time and again, there have been different classifications of acute pancreatitis. The recent classification is the revised Atlanta guidelines around 2020. So they have classified acute pancreatitis into mild and severe disease, and they have added moderately severe one also. Depending upon the type of injury, the acute pancreatitis can be classified as interstitial type and necrotizing type. So this is in just about what has been described by the revised Atlanta guidelines. As I said, it classifies acute pancreatitis based on its severity into mild, in which there is no local or systemic complication or there is no organ failure. Now, severe can be moderately severe or severe when there is a transient organ failure for less than 24 hours with or local complications. It is moderately severe when this organ failure is multiple and it's persistent for beyond 2 days, along with local or systemic complications. Then it becomes severe acute pancreatitis. Now, depending upon the types of pancreatitis, interstitial pancreatitis and necrotizing pancreatitis, there can be fluid collections in and around pancreas. Whether this fluid collection is organized or not classifies them into early one and late one. In interstitial pancreatitis, the early fluid collection is called as acute peripancreatic fluid collection, and beyond 4 weeks, it is called as pseudocyst. Remember, these fluid collections are clear without any solid contents within. As a sequelae of acute necrotizing pancreatitis, patients can have fluid accumulation in and around pancreas similar to interstitial pancreatitis. However, what differentiates this from the previous is this will have solid debris within. So, early fluid collection in an acute necrotizing pancreatitis patient is called as acute necrotic collection, ANC. When the same one is walled off, systemic complications are gone off beyond 4 weeks, then it is called as WON or walled off pancreatic necrosis. The basic cause is either duct obstruction or acinar cell injury or due to metabolic complications like defective intracellular metabolite transport. Cholelithiasis, concretions, ampullary obstructions, and chronic alcoholism all lead to ductal obstruction, which in turn leads to interstitial edema, ischemia, and ultimately culminate into acinar cell injury. Drugs, trauma, ischemia, and viruses, which I forgot to tell in the causes, which are rare, but yes, they do happen, cause direct acinar cell injury in which they release the proenzymes and some of them get activated and end up with multiple acinar cell injury, and that leads to pancreatitis. And the last one is metabolic injury, which delivers the proenzymes and the lysosomal component. Intracellular activation happens within itself. That will again lead to acinar cell injury. Now, once the acinar cell injury happens, we all know protein, fat, and carbohydrate digestion takes place with the help of pancreatic enzymes. They get activated, which starts a cascade. What does it do? There is an interstitial inflammation edema. There is a digestion of protein by proteases, digestion of fat by lipase and phospholipases, and the elastase enzymes can damage the vessel wall, which may lead to hemorrhage. A combination of all these end up in acute pancreatitis. So we saw what causes and what is the mechanism of acute pancreatitis. Now, how to diagnose them? See, 3 criteria are described, out of which 2 is required to define that the patient is having acute pancreatitis. One is symptoms, second is biochemical investigations, third is imaging. So typical history of severe epigastric pain radiating to back, which is alleviated by leaning forward and exacerbated by movement, is clinical. 3 times upper limit of normal elevation of serum amylase or lipase is biochemical. And imaging features, it can be ultrasound or CT or MR, which are consistent with acute pancreatitis. Remember, out of these 3, just 2, if they are consistent, then we can diagnose confidently acute pancreatitis. Now, which modality is preferred? Imaging. Contrast enhanced CT is the preferred imaging modality, and it's advisable to be prescribed or done 72 hours after the onset of pain. This is because when we do initially, we may underestimate the extent of pancreatitis, extent of necrosis, early complications, all those things can be definitely missed. So we may end up with a diagnostic uncertainty, and we may miss complications which may develop after 48 hours also. So when we diagnose with an ultrasound, typical history and biochemical parameters, we can get a CT after 72 hours or when the patient deteriorates. So this is how an interstitial pancreatitis looks with surrounding fat stranding. This is how necrotizing pancreatitis looks, where there is severe surrounding fat stranding. We are seeing areas of non-enhancing pancreas and probably fluid collections or edema, which is tracking down into or surrounding the left kidney. Now, there are CT scoring systems which classify pancreatitis depending upon the severity of inflammation, severity of necrosis, and extrapancreatic complications into mild, moderate, and severe. So this is shown in this picture. We already discussed fluid collections of pancreas, like interstitial pancreatitis leading to acute peripancreatic fluid collection, chronic pseudocyst. Necrotizing pancreatitis, acute collection is acute necrotic collection, chronic is walled off necrosis. So as we discussed in interstitial pancreatitis, the fluid collection is homogeneous without any solid component, whereas in walled off necrosis, they will have solid component, particularly when they have gas, it is likely to be infected. Now, what is the prognosis of acute pancreatitis? The severity of pancreatitis determines the prognosis. Now, as we saw, the development of organ failure, whether it's transient or it's going to be a prolonged one, whether the systemic inflammatory response is going to be severe or mild, determines one's severity. So persistent SIRS, if it is present, it was associated with mortality in 1 in 4 people, whereas it was only 1 in 16 for transient SIRS. There are scoring systems which help us to prognosticate time to time, like not a single scoring system, it's a dynamic scoring system. For example, patient got admitted with pancreatitis today, tomorrow we can derive a score. Same score can be derived after 2 days, and depending upon the trend, we can prognosticate. Lots of scoring systems are available, but the very commonly used one include Apache 2, Ranson, and modified Glasgow scores. None of them are superior to the SIRS in predicting the mortality. However, these can predict whether the patient is going to deteriorate or not. So having seen the causes, the mechanism, the diagnosis, now how to manage them. So earlier phase, no early phase drugs are available to mitigate the disease progression. However, it's broadly supportive. So aggressive fluid resuscitation, earlier it was very aggressive, but these days moderately aggressive resuscitation based upon resuscitation goals. Patients usually have severe pain, so we need to manage them. Acute pancreatitis patient may have difficulty in eating and may have difficulty in digesting. So nutritional support properly has to be established. And once patient is not improving, we should not shy away in doing investigations or repeating investigations to identify any complications. Tackling infections, if identified properly with superior or high-grade antibiotics, and depending upon the etiology, we need to tackle the reversible causes and interventions if it is required, like local complications are there, then there are lots of options available like endoscopic, laparoscopic, intervention radiology, and all those things which we will see. So initial resuscitation earlier, it was a goal-directed one. Sorry, thank you. So initially it was a goal-directed, it was not a goal-directed one initially. It used to be significant fluid resuscitation in the form of 200-250 ml per kilogram of body weight. So it was believed that such a large quantity fluid is required to bring or to compensate the fluid lost into the third space so that the patient doesn't go in for systemic shock. But often late, we found that when we give aggressive fluid, they end up with lots of complications, including pulmonary edema, and the morbidity increased. So goal-directed IV fluid resuscitation with ringer lactate solution to be given at a rate of 5 to 10 ml per kilogram per hour until the resuscitation goal are reached. For example, the resuscitation goals can be improving the central venous pressure, improving the collapsibility of IVC with repeated ultrasound screening, or the urine output. In addition to this, we need to give analgesics and antiemetics. This is the most important one, the IV fluid resuscitation, which is goal directed, is the most important one, which has to be started as early as possible. And this determines whether the patient is going in for a transient or a definitive organ failure. Now, are there any objective ways of goal directed ones? Yes, we can do a blood gas, and depending upon the lactate, we can adjust the fluid resuscitation. The waterfall trial initially showed that 20 ml per kg bolus followed by 3 ml per kilogram was associated with increased risk of fluid overload without clinical benefit. So just 5 ml per kilogram per hour was given in these patients. That led to decrease in the morbidity caused due to fluid overload. Now, fluid therapy prevents acute kidney injury, hypovolemia. If not treated properly, will lead to circulatory failure, which ultimately culminate into multiple organ failure. So, what are things to be noted? We need to have an urine output more than or equal to 0.5 ml per kilogram per hour every hour. The hematocrit should be less than 44%. In other words, hemoconcentration should be avoided. Central venous oxygen saturation should be above 70%. Tachycardia should not be there. And mean arterial pressure should be maintained between 65 to 90. So these are the objective goals. Now, once the nutritional initial IV fluid resuscitation has been done, nutrition support has to be taken care. We all know that enteral nutrition is the best nutrition. Whenever possible, as early as possible, we need to ensure that patient starts eating. If the patient is not able to eat, then we can start them tube feeding, which can be in the form of NG or NJ tubes. It has been identified that NG tube, nasogastric tube, is not inferior to nasojejunal feeds unless patient is having a gastric outlet obstruction or gastroparesis. When significant ileus or significant local complication precludes ingestion or digestion of enteral feeds, only then parenteral nutrition has to be started. And remember always, enteral feed is much, much superior to parenteral feed. Now, when to start? We can start very early, less than 24 hours, or we can start greater than 72 hours. They didn't have any difference in the outcome. But how to determine this? Once the initial resuscitation is over, pain has come down, the bowel movements have started, and patient is able to tolerate enteral feeds. That is when we need to start them. Significant pain will be there. How can that be managed? NSAIDs are usually avoided. We give opiates in the form of morphine or fentanyl. We start with a weak opioid and slowly, the WHO step-up pattern, we give strong opiates if the pain is not settled. Few people or few patients may require insertion of an epidural, and analgesic should be given through that. Any role of antibiotic? There is no role of antibiotic as a prophylactic basis. If the patient is deteriorating and if we suspect infection in a patient of an acute pancreatitis who has a fluid collection, then we quantify them with procalcitonin or we do an imaging. In the imaging, there is a fluid collection which has a gas inside. We take a needle aspiration and send them for culture and then start them on broad spectrum antibiotic and taper them according to the culture sensitivity report. A broad spectrum antibiotic which covers both gram-positive and gram-negative has to be started, preferably pinims. So meropenem is the preferred antibiotic. Remember, if the patient is there in ICU for a long time, he has been already taking multiple antibiotics. There is fluid collection inside which has been meddled multiple times. Still patient is having fever. We need to start them on antifungals also. Do all patients require invasive pancreatic interventions? No. Severe acute pancreatitis observed less than 24 hours due to a gallstone can be managed with an early ERCP. If the patients have peripancreatic fluid collections which are persistent and causing obstructive symptoms, they are not decreasing in size. Obstructions in the form of biliary obstruction, gastric outlet obstruction, they can be tackled. We already noticed it can be tackled endoscopically, it can be tackled surgically, laparoscopically, it can be tackled with intervention. Now, if it is a pseudocyst, it can be managed with endoscope. If it is walled off necrosis, again, it can be managed with endoscopic intervention like endoscopic necrosectomies, in which whenever stomach has good amount of contact with walled off necrosis, we introduce a stent which holds the wall of pancreatic necrosis and the wall of stomach together, and it's a self-expanding metallic stent. Now, through this metallic stent, endoscope can go inside and remove all necrotic debris. If this is difficult, or if it is not close to the stomach, then it can be tackled with a laparoscope or an intervention radiology in the form of percutaneous drainage. Initial antibiotic therapy is failing to cure a fever or infection in this patient, then walled off necrosis has to be drained. So there are Panther trial, there is Pointer trial, in which when we delay the drainage for more than 4 weeks, we resulted in fewer complications and outcome was significantly good when compared to that of early drainage. That is why step-up approach is always preferred in terms of major complications and mortality. So initially, least invasive approaches like endoscopic or intervention radiology approaches increase the size. They are not responding, then do surgery, which can be preferred as laparoscopy, and only then open surgery. Because open surgery directly in the first intervention itself without doing any endoscopy or percutaneous drainage. In this study, there was an increased amount of exocrine endocrine insufficiency and incisional hernia and mortality when compared to that of step-up approach. So this is a special condition called as gallstone pancreatitis, which is very common cause in females. If it is mild acute pancreatitis, we can do a cholecystectomy in the index admission itself. If it is severe acute pancreatitis, if the patient is having acute cholecystitis also, then percutaneous cholecystectomy has to be done. If the patient doesn't have cholecystitis, then delay the cholecystectomy till the patient is recovering completely from the acute pancreatitis sequelae. So what happens in the long term? Recurrent acute episodes may ultimately lead to chronic pancreatitis, which can end up with endocrine exocrine insufficiency. A severe acute pancreatitis can lead to new onset endocrine insufficiency in the form of diabetes, approximately in 39 or 40% of the patients. Exocrine insufficiency is seen in 30% of the patients. We have to identify them early and start treating them. 1/4 of them recurrent episodes can go, and out of which 1/4 can go for chronic pancreatitis. So I have discussed everything in detail of where we stay today for acute pancreatitis. I would like to tell them in a gist with flowchart in the next couple of slides. So whenever there is acute pancreatitis patient, we start with fluid resuscitation, which is goal directed. Nutrition support has to be taken care of. Once initial resuscitation is over, enteral feeds preferably has to be started. Only if enteral feed in the form of oral or tube feeding is not feasible, then parenteral nutrition has to be given. Pain management has to be appropriate, should be step-up approach. Patient is worsening, antibiotics accordingly can be started, and imaging has to be done at regular intervals to identify why the patient is deteriorating and should be managed. Now, there are no complications, can be discharged early. If it is due to gallstone, we can do a cholecystectomy in the index admission itself. Now, there are local complications like a peripancreatic fluid collection or acute necrotic collection. If the patient is developing new onset infection, then we may need to start them on antibiotics after taking a fine needle aspiration. Now, if there is an extra pancreatic infection like urinary tract infection, chest infection, those have to be imaged, sampled, and antibiotic should be started. If there is a collection with the procalcitonin very, very high, then start them on broad spectrum antibiotic. If procalcitonin is not high, there is a gas in collection, this also has to be treated with antibiotic. More than 2 weeks of persistent clinical deterioration, despite procalcitonin being normal or there being no gas within the collection, also should be considered as an infection. In other terms, we titrate the requirement of antibiotic for a peripancreatic fluid or an acute necrotic collection in pancreatitis. How to claim or how to predict that there is a infection in it? With increased procalcitonin, with the gas within the collection, and 14 days it is not improving, or a fine needle aspiration proven by culture. Now the patient is improving, stop antibiotic and discharge the patient. If it is not improving despite giving antibiotics, we need to do interventions which can be in the form of step-up approach. Feasible one, do endoscopy when you have a very good endoscopic setup and technical assistance available. If it is not available, then we may need to do percutaneous drainage. If patient is improving, it's fine. If he is not improving, then we have to step up, like upsize the catheter or go in for laparoscopy, and finally only go for open surgeries. So thanks for the patient listening. In case of any doubts, I'm here to clarify yours.
Thank you so much, sir. So that was really one hell of a session on pancreatitis, and we really enjoyed it thoroughly, and we learned so much, so many new things, and so much from this thing. And I would now like to invite Professor Konzo, Dr. Bhatti sir, and Dr. Mongardini to present their comments and to discuss if there are any things that can be discussed upon this topic. And also, all the participants can put up their questions in the comment box that will take up towards the end of the session.
Yeah. Thank you, Dr. Santosh. It was a very nice presentation on acute pancreatitis. So, Dr. Federico is there, I think. Hello.
Yes, I'm here.
Yes.
Yeah.
Yeah. How are you, Dr. Federico? We met in the last session.
Yeah, we met in last session. Unfortunately, Professor Conzo is in the OR. He have an emergency, so he needs to go there. So he's not online with us in this moment. He
Okay.
appear only for that. And I think the acute pancreatitis is a problem, an important problem, and the surgery have just little bits of space, probably when we have many other stuff, many other classifications. I have seen the Atlanta one, but and also the other CT scan classification. But we have many other classification with points that can make a different kind of evaluation. But I think it was a really nice, especially the flow chart when how to do when you have an acute pancreatitis with necrosis, especially the necrotic or hemorrhagic one. So I think it was a really nice lesson, and a lot of people can enjoy many stuff about it. Yeah.
Yeah, Dr. Federico, my query to you is, do you think you see both the gallstone-induced pancreatitis and alcohol-induced pancreatitis? So, what do you think that which is more severe in your patient, or does any severity affected by the etiology of the pancreatitis?
In
Like
in
here, like
Mhm.
gallstone-induced pancreatitis in females, and there's alcohol-induced most commonly we see in male patients. So does the severity is that different in both these etiologies, or do you feel there's no difference in the severity of the pancreatitis or the complication of the pancreatitis when etiology is either gallstone, on the other hand, on one hand there is a gallstone, on the other hand there is alcohol.
Usually in our institute we don't see many patients with the with the demographic part by the alcohol. We see many times from the gallstones, not many
Yeah,
times from the alcohol. And usually, so we don't have the correspondence to make a comparison between both. So many of them comes from the gallstones. So and I think that it depends. The severity is really in a range. We have a very really big scenario, but we know that when the pancreatitis is a necrotic hemorrhagic one, usually we don't have to. Usually we do not arrive to the surgery. Usually we stand up following this step up approach. We can stop with the drainage, and sometimes they are successful. When they are not successful and we need to do the necrosectomy, we can do the necrosectomy by surgery,
yeah,
but really small percentage. So
yeah. Surgery
it was really,
definitely. Surgery comes in the very last in the picture.
yeah,
Initial all management either is minimally invasive or either medical management in the initial weeks of the pancreatitis.
yeah.
That is now well accepted.
Yeah, and not only, but I already talked with Dr. Raghav, and I told him that we had a case 5 days ago
Yeah,
about the patient, really strange case that we will publish in a case report with the help with the aid of our gastroenterologist, because we know that chronic pancreatitis typically present with debilitating abdominal pain and recurrent inflammatory episodes. But we present a rare case and a diagnostically challenging case of a silent idiopathic chronic pancreatitis. And it was made by massive pancreatitis in a completely asymptomatic 50 years old female. So it's something that usually in our experience doesn't happen. We have usually a big amount of symptomatology, and in this case she was totally without abdominal pain and only minimal occasionally steatorrhea and just a little bit of prior episode of acute pancreatitis. So it was something so nice, and I think that we need to publish in a case report something about it.
yeah, sure. And my next query to Dr. Federico is, you do see more of the gallstone-induced pancreatitis. Yes, that's what you told. So
Sorry, repeat, please.
you do see more cases of the gallstone-induced pancreatitis at your
Yes,
place.
yes.
Yeah, less
Usually is made by gallstone.
usually more cases of the gallstone. So you perform the cholecystectomies before discharge with the any mild pancreatitis patient, or what time you are going to do surgical removal of the gallbladder in those cases of the gallstone-induced pancreatitis? What's your practice?
Usually
Yeah,
usually in our practice, if there are the possibility, it depends on the on the stones. But usually when we look at something like acute pancreatitis, usually we have in mind to make something like an ERCP, and we will we used to postpone the gallbladder surgical intervention by usually 2 weeks, something like that, after the ERCP. And how do you do in your
we most of the cases the stone is passed away. It's not there in the CVD. So ERCP we feel very rarely required for those patients.
okay?
So the stone, it goes away into the duodenum. It's rarely stuck into the ampulla. So if we consider ERCP only if the stone is stuck in the distal CBD. Regarding cholecystectomy, we perform in a mild case of the pancreatitis. We perform before the discharge of the patient. Like in the same hospital stay, we do the laparoscopic cholecystectomy in a pancreatitis without any organ failure. Or there is a
Okay.
mild pancreatitis we consider because there are chances of the recurrent attack. So only in severe case we will wait for uh, laparoscopic cholecystectomy. Otherwise, mild case we will do cholecystectomy in the same hospital setting before the discharge of the patient.
Yeah, when it will be a mild one, for sure we also will do
Yeah.
in the same situation. We will enlarge a little bit the hospitalization and the hospital stay, and then we will do the cholecystectomy in the same time. But usually, mild situation is not so frequent. So when we have something like that, usually we have not the same case that you have. We have something a little bit less with the numbers. So when we have it, usually we need to postpone it. We need to do ERCP, and then we will do it after 2 or 3 weeks. Yeah, something like that.
Okay, fine. Any queries from the participants we would like to take?
Yes, sir, there is one. Dr. Sayed is asking, when should CT scan be done in acute pancreatitis and when is it unnecessary? What is the role of ultrasound versus CT versus MRI in pancreatitis evaluation?
I think Dr. Santosh will answer this.
Okay, I will take the question, sir. So CT, the indication for CT are three things. One, when the diagnosis is uncertain. Two, when there is a deterioration in the clinical scenario of the patient. Three, when we are planning for any intervention to give us a roadmap. These are the only three indications for CT in a patient with acute pancreatitis. Now, the second part of the question, ultrasound versus CT with MRI. Ultrasound is definitely enough in a patient with classical symptoms and an elevated amylase or lipase as an initial part of imaging in acute pancreatitis. And in follow-up, like patient is having a clear pseudocyst, which is decreasing in size, just to follow up without any intervention, ultrasound is enough. Now, MRI, see these patients when have recurrent acute pancreatitis, we have to do an MRI with MRCP to see whether there are microliths, cholelithias with microliths, number one, or number two, pancreas divisum. In rest of all indications, CT scores better than ultrasound and MRI because it can give you an idea about the severity of pancreatitis. It can give you an idea about the collections around the pancreatitis and complications. It can also give you an idea about vascular and biliary complications surrounding pancreas.
Yeah, thank you, Santosh. For the young people here, I would like to add we should also consider erect X-ray in almost all the patients because sometimes acute abdomen perforation peritonitis with the raising amylase can
Yes.
present as all similar symptom of the acute pancreatitis. So very simple investigation of erect X-ray will give us the diagnosis. So this basic USG and X-ray are enough for the case of pancreatitis. CT usually is not required. And as Dr. Santosh has told, when the diagnostic dilemma or any issue with the diagnosis, then we do consider for the CT. But we should also consider erect X-ray. In almost all of these patients, I would say, a very simple investigation and which may give us the diagnosis as well. Thank you.
Indeed, sir. Thank you so much. Sir. That was a really good point of an erect X-ray and very cheap investigation and very basic investigation that can be done initially and that can guide the treatment. Sir, another question is we are getting um, fluid management of patient of CLD pancreatitis.
Okay,
Uh, yeah.
I will take this question again. See, the combination of CLD with pancreatitis per se is very rare. Having said in alcoholics, this is possible. Uh, CLD, again, lots of crystalloids is going to worsen it. So whatever the background disease, it should be goal directed. Now, the type of fluid what you give differs. Albumin is usually not preferred in routine acute pancreatitis patients, whereas in CLD, we may need to give albumin more than crystalloids because lots of crystalloids with the background of CLD in a pancreatitis patient, the ascites is going to get worsened. So, albumin and other crystalloids may be preferred, colloids may be preferred over crystalloids in a patient with CLD. However, the goal-directed fluid resuscitation is same in either CLD or a non-CLD patient. Like tachycardia should not be there. Mean BP should be 60 to 95. 0.5 ml per kilogram per hour of urine output. Lactate being normal. All those are goal-directed therapies.
Thank you, sir. I hope it was very helpful, and I hope it did answer the exact query. And yeah, so if anyone has any more questions